Welcome back to the Deep Dive. We're the show that really tries to cut through all that textbook density. We want to pull out those vital nuggets you need, not just to be informed, but, truly confident in your nursing practice. Today, we're plunging right into the essence of life itself. Blood. Specifically, we're doing a deep dive into hematologic problems, using Lewis's medical surgical nursing as our guide. Our mission today, pretty clear. Unravel the complexities of common blood disorders. We want to give you, our awesome nursing student listeners, a clear, engaging, and really actionable understanding of what you need to know for assessment, diagnosis, management. Think of it like connecting the dots from the textbook page to actual patient care.
And that connection is absolutely key because when we talk hematologic problems, we're not just talking about isolated issues, not at all. We're really looking at how these conditions hit fundamental concepts, things that underpin all patient care, like cellular regulation, gas exchange, immunity, infection, and critically, how they affect things like clotting, fatigue, pain, functional ability, perfusion. Grasping these core ideas, seeing how they all sort of weave together, that's the real key to holistic care.
Okay, perfect. Let's start our journey then with a really big one, anemia. It's a term we hear constantly, right? But what does it actually mean for us as nurses?
Well, simply put, anemia isn't really a disease itself. It's more like a...
Demonization.
a signal, a red flag from the body telling us there's a deficiency in red blood cells, maybe a problem with hemoglobin quality or quantity, or even just the volume of packed red cells. Bottom line, the body isn't getting enough oxygen. That's a perfect way to frame it. Because as nurses, we then sort of become detectives, right? We classify anemia in two main ways to help us narrow down that underlying cause. First is by morphology. Basically how the red blood cells look under the microscope. Think of it as a diagnostic snapshot. Are they microcytic, small and pale? That often points towards iron deficiency or maybe thalassemia. Or are they macrocytic abnormally large? That makes us think about B12 or folic acid deficiencies. Or maybe they're normocytic, normal size and color. That could suggest acute blood loss or maybe chronic kidney disease.
Okay, that makes sense. Looking at the cells themselves, and then maybe even more practical for patient care, we classify by etiology, right, by the cause. Is the body losing too much blood, like from a GI bleed? Is it failing to produce enough red blood cells?
Yeah.
Or is it destroying them too quickly, like what we see in sickle cell disease?
Exactly. And knowing these classifications isn't just academic. It guides our entire assessment.
Right.
And the manifestations you'll actually see in a patient, they vary dramatically. It depends on how quickly the anemia develops and just how severe it is. We categorize this broadly. With mild anemia, think hemoglobin between 10 to 12 patients might not notice much. Maybe just a little fatigue, some shortness of breath, but only with really strenuous exercise.
Okay.
But as it progresses to moderate anemia, say hemoglobin 6 to 10, those symptoms, palpitations, dyspnea, fatigue, they start showing up even when the patient is just resting. And then severe anemia below 6 GDL. Well, that's when multiple body systems are basically screaming for help.
And you'll see some pretty striking skin changes too, won't you? Like pallor is the classic one, right?
Yeah.
Directly from low hemoglobin. But interestingly, if the anemia is from rapid red blood cell destruction, like hemolysis, you might actually see jaundice and maybe even itching.
That's right. And cardiopulmonary-wise, the heart kicks into overdrive to compensate. It increases heart rate, stroke volume, trying to maintain cardiac output. This can lead to systolic murmurs, sometimes even bruits. And in those severe chronic cases, that constant overwork puts patients at real risk for angina, MI, even heart failure. The body's trying, but eventually it struggles.
Wow. So as nurses, our assessment is like a critical treasure hunt for all these clues.
Absolutely. Subjectively, we're asking about their health history, any recent blood loss, chronic diseases, medications like aspirin or NSAIDs, and crucially, their diet. What are they eating? Objectively, beyond that pallor and increased heart rate, you'll be looking for signs like hepatosplenomegaly, maybe neuro changes like confusion or an unsteady gait, especially in older adults.
Okay.
Our planning goals. Always focused on getting the patient back to their normal activities, ensuring they have adequate nutrition, and preventing those really devastating complications.
And implementation-wise, the first priority is always to fix that underlying cause, right?
Right.
So that can mean blood transfusions, maybe specific drug therapy, or even oxygen to stabilize things. And for that fatigue, which sounds pretty pervasive, encouraging alternating rest and activity makes sense. Plus, emphasizing diet foods rich in iron, B12, folic acid, protein, all those building blocks for red blood cells.
And here's a vital nugget for your practice. Anemia is not a normal part of aging. In older adults, manifestations like confusion, ataxia, weakness, They're often just chalked up to getting older, but that can lead to delayed diagnosis. So always dig deeper. Don't just assume it's age.
That's a great point. Okay, now here's where it gets really interesting, I think. Drilling down into specific types of anemia. Let's kick off with iron-deficiency anemia, which is like hands down the most common nutritional disorder in the world, right?
It really is.
Mm-hmm.
And the main culprits, well, inadequate dietary intake, which can be surprising in developed countries sometimes, malabsorption, especially after GI surgery, and critically, chronic blood loss. This bleeding can be subtle, insidious. We're talking maybe 50 to 75 milliliters of blood loss from the GI tract, enough to make stools look black, Melina, but the patient might not even realize they're bleeding.
That subtle GI bleeding, that's a key thing for nurses to remember, definitely. So for diagnostics, the lab values are kind of our roadmap.
Exactly. You'll see low hemoglobin, low hematocrit, low MCV that tells us the cell size is small, plus low serum iron and low ferritin, which reflects iron stores. Interestingly, the total iron binding capacity, or TIBC, is often high. The body's basically desperate to bind more iron.
Okay.
Beyond labs, stool, occult blood tests, endoscopy, colonoscopy, those are crucial for finding the source of that blood loss.
And nursing management, again, is about treating the cause and replacing that iron.
Right.
Now, when it comes to replacing iron, oral iron is usually the first step, like ferrous sulfate or gluconate.
Correct. That's the first line.
And key point, it's absorbed best in an acidic environment. So tell patients take it an hour before meals, maybe with vitamin C or orange juice to help absorption. Also need to prepare them for side effects, right? GI upset, nausea, constipation, and those black stools, which are common but harmless.
And liquid iron needs to be diluted, taken through a straw, prevents staining the teeth.
Good tip. And if they can't handle oral iron?
Then parenteral iron, IM, or IV becomes necessary. For IM, you need to use the Z-Track injection technique to avoid skin staining. And for IV iron dextrin, a test dose is absolutely critical. We have to watch for anaphylaxis.
Okay. And this isn't a quick fix, is it?
Not at all. Patients usually need therapy for 2 to 3 months after their hemoglobin levels return to normal just to replenish those body stores fully.
Got it. Long-term commitment. Okay, let's shift to megaloblastic anemias.
Right. These are characterized by those abnormally large, fragile red blood cells. It happens because of impaired DNA synthesis. The main culprits are deficiencies in cobalamin, that's vitamin B12, and folic acid. What's really fascinating about cobalamin deficiency, especially pernicious anemia, is that the problem isn't always intake. Often it's the lack of intrinsic factor. That's a protein made in the stomach that's essential for B12 absorption. This can happen due to gastric mucosal atrophy, maybe autoimmune destruction, GI surgeries, Crohn's, celiac disease. Even strict vegetarianism can put you at risk.
And the manifestations here are pretty unique, aren't they? Beyond the usual anemia symptoms.
They are. You often see GI issues like a sore, red, beefy, shiny tongue,
Right.
anorexia. But the critical distinction is the neuromuscular involvement.
Right. The weakness, paresthesias, tingling in hands and feet, reduced vibratory sense, ataxia, even cognitive issues. That's specific to B12 deficiency.
Exactly. You contrast that with folic acid deficiency. It also causes megaloblastic anemia, similar general symptoms. But, and this is a key clinical nugget, you don't see those specific neurologic symptoms.
Okay, no neuro symptoms with folic acid deficiency. Got it.
Causes for folic acid deficiency: things like chronic alcohol use, poor diet, malabsorption syndromes, certain drugs. Management for both really focuses on replacement therapy, lifelong IM, or sometimes intranasal B12 for pernicious anemia, oral folic acid for that deficiency.
And nursing care sounds like it's heavily focused on patient education, especially diet and injury prevention if those neurodeficits are present.
Precisely. Safety becomes a big concern.
Okay, let's shift gears again. Sickle cell disease, SCD, this is a really critical inherited disorder, autosomal recessive.
Yes, primarily affecting individuals of African, Mediterranean, and Middle Eastern descent. It's defined by an abnormal hemoglobin, hemoglobin S. And here's the core problem. In low oxygen situations, think hypoxia, infection, dehydration, even just stress, these red blood cells stiffen up. They take on that classic crescent or sickle shape, and they become rigid.
And those sickled cells, they're the real troublemakers.
Absolutely. They can't flow easily through small blood vessels. They get stuck, causing vascular occlusion. This is what we call a vaso-occlusive crisis. It leads to profound tissue ischemia, infarction, intense pain, and hemolysis, the breakdown of those fragile cells.
So patients typically present with anemia, maybe pallor, sometimes a grayish skin cast. Jaundice is common too, right, from all that cell breakdown. Leads to gallstones even.
That's right. But the hallmark symptom, the thing that often drives them to the ED, is that severe pain during a crisis. It can affect the back, chest, extremities, abdomen, often comes with fever, tachypnea, hypertension too.
And the complications of SCD sound really wide-ranging, affecting almost every sister because of those repeated sickling events.
They are. Infection is a huge cause of mortality. Why? Because the spleen, which is vital for immunity, gets damaged early on. It's called autosplenectomy.
Wow.
Acute chest syndrome is another really severe complication. Patients present with fever, chest pain, respiratory distress. It's a dangerous mix of pneumonia, tissue infarction, maybe even fat embolism.
Scary.
And other issues.
Yeah, pulmonary hypertension, stroke, renal failure, chronic leg ulcers, priapism. The list goes on. It gradually impacts everything.
Okay, let's try to put this into practice. A mini scenario. Imagine 21-year-old black woman comes into the ED. She just got back from a ski trip in Colorado, high altitude, right?
Sure.
She's in excruciating pain in her chest and abdomen. She's short of breath. O2 sat is only 86%. Vitals, HR 110, respiratory rate 28, and you hear crackles in her lungs. History. 6 previous ED visits for sickle cell crises. As the nurse, what are your immediate priorities? What's the very first thing you do? Okay, yeah, that scenario absolutely screams emergency.
Yeah.
First things first. That 86% O2 sat is alarming. We have to reverse the hypoxia immediately to stop more sickling. So oxygen therapy is priority number 1, no question.
Right. Oxygen first.
Then that excruciating pain, aggressive pain management, non-negotiable. We're often talking large doses of continuous opioid analgesics, maybe PCA, plus adjunctive meds like NSAIDs.
I remember a seasoned nurse telling me once, if you think you're giving enough pain meds in a sickle cell crisis, you're probably not. It really highlights how intense that pain must be.
That's absolutely spot on. It's often undertreated. Beyond oxygen and pain, prompt IV hydration is vital, helps reduce blood viscosity, maintains renal function, and rest to decrease metabolic demands.
And don't forget DVT prophylaxis, right?
Critical. And any fever needs immediate attention treated as an emergency because of that high infection risk.
Makes sense. And long-term, it's all about patient education, avoiding triggers like high altitude, dehydration, getting immunizations.
Exactly. Prevention is huge for managing SCD long-term.
Okay, one last stop in the anemia spotlight. Aplastic anemia.
Right. This is a serious one. The bone marrow essentially just gives up. It stops producing enough cells. You end up with pancytopenia, a decrease in all blood cell types. Red cells, white cells, platelets.
And the bone marrow itself looks hypocellular, often because of an autoimmune attack.
Often, yes. So the manifestations are general anemia symptoms, plus a really high risk of infection from neutropenia, low white cells, and a severe bleeding risk from thrombocytopenia, low platelets.
Management sounds focused on finding and removing the cause, supportive care like preventing infection and bleeding, and then more intensive things like stem cell transplant or immunosuppression.
That's the gist of it, yes. Supportive care is key while figuring out the next steps.
Okay, we've covered a lot on red blood cells and oxygen. Now let's shift gears. Let's talk about clotting. What happens when the body's really intricate system for stopping bleeding goes wrong? Let's dive into hemostasis disorders.
Right. And a critical question for you as nurses is what happens when platelets, those tiny cells crucial for clots, are too low? That's thrombocytopenia. Platelet count below 150,000. This immediately puts a patient at risk. Prolonged bleeding from minor trauma or even spontaneous bleeding in severe cases.
And the causes can vary, like problems destroying them too fast or them getting trapped somewhere.
Exactly. Impaired production, increased destruction, often immune-mediated or abnormal distribution, like sequestration and an enlarged spleen.
And there are a few key acquired types we really need to know.
Definitely. Immune thrombocytopenia, ITP, that's where antibodies just destroy platelets.
Yeah.
Then thrombocytopenic purpura, TTP, that involves widespread platelet clumping, forming microthrombi, often linked to a deficiency in an enzyme called ADAM-TS13. And critically important, heparin-induced thrombocytopenia, HIT. This is a severe immune reaction to heparin itself. It causes platelet destruction and, paradoxically, a high risk of dangerous clots, thrombosis.
Wow, heparin causing clots. That's counterintuitive.
It is. It's an immune complex reaction.
Yeah.
Very serious.
So manifestations of thrombocytopenia are mostly about bleeding. Mucosal, skin bleeding.
Almost always. You'll see epistaxis, nosebleeds, gingival bleeding, petechiae, those tiny pinpoint red spots, purpura, which are larger patches, easy bruising. And here's a critical number to remember. If the platelet count drops below 20,000, Life-threatening spontaneous bleeding like an intracranial hemorrhage becomes a real risk.
Okay, under 20,000 is danger zone.
Big danger zone. Diagnostics beyond just the platelet count involve specific assays to figure out which type it is, like an ITP-IgG test or testing for that PF4 heparin complex in HIT.
So nursing management. The primary goal seems pretty clear. Prevent and control bleeding.
Absolutely. And patient education here is paramount.
Right. Telling patients to report any signs of bleeding immediately, like black, tarry stools, bloody vomit, sputum, urine, new bruising, vision changes, headache.
All of that. And they absolutely must avoid aspirin, other drugs that affect platelets. Restrict vigorous activities. Use gentle hygiene, soft toothbrush, electric razor. Avoid forceful nose blowing. No tampons for women. Use pads instead.
These seem like simple things, but they can prevent major complications.
Huge difference.
Okay, moving on. What about inherited bleeding disorders like Hemophilia and Von Willebrand disease?
Right. Hemophilia A and B are X-linked recessive, so they mostly affect males. Caused by a deficiency in specific coagulation factors, factor VIII for A, factor IX for B. Von Willebrand disease, though, is much more common. It affects both men and women, usually inherited autosomal dominant. It involves a deficiency or dysfunction of von Willebrand factor.
And von Willebrand factor does two things, right? Helps platelets stick together and carries factor VIII.
Exactly. So its deficiency affects both platelet function and the coagulation cascade.
Manifestations for all of these sound like they relate directly to that impaired clotting.
Precisely. Prolonged or delayed bleeding after minor cuts or bumps. Uncontrollable bleeding after dental work. Frequent nosebleeds. GI or GU bleeding. Significant bruising or hematomas, which can lead to dangerous compartment syndrome. And critically, hemarthrosis. Bleeding into the joints. This is particularly devastating over time. Causes chronic pain, joint damage, crippling deformities.
That joint bleeding sounds awful. So management is mainly replacing the missing factor.
Primarily, yes. Factor replacement therapy. Often given prophylactically, especially in severe hemophilia, to prevent bleeds from even happening. For milder hemophilia A and von Willebrand disease, DDAVP desmopressin can sometimes be used. It helps release stored factor VIII and von Willebrand factor. Antifibrinolytics can also help stabilize clots once they form.
And nursing care. Controlling bleeding if it happens, direct pressure, ice. That RICE protocol, rest, ice, compression, elevation for joint bleeds?
Yes, and analgesics for pain, but strictly avoiding aspirin or NSAIDs that affect platelets.
Patient education is key too, right? Genetic counseling, injury prevention, non-contact sports only, and wearing a medic alert tag.
Absolutely essential for long-term management.
Okay, now for something really complex. Disseminated intravascular coagulation, DIC. You called it a medical paradox.
It really is. It's one of the most challenging conditions, I think, because the body is simultaneously experiencing widespread abnormal clotting and uncontrollable bleeding. Imagine the clotting system just goes haywire. It starts forming tiny clots everywhere, using up all the platelets and clotting factors.
And then everything's used up.
Exactly. Then the body can't form clots where it needs to, and you get massive bleeding. It's never a primary disease itself. It's always triggered by something else.
Like sepsis, major trauma, cancer, obstetric complications.
Those are the big triggers, yes.
And the pathophysiology is just this vicious cycle. Triggering event, widespread clot formation, organ damage from clots, and consumption of factors. Then the clot-busting system kicks in, overdrive, releases products that act like anticoagulants, blood can't clot, passive bleeding.
You've got it. Widespread thrombin leads to fibrin deposition, damaging organs. But then fibrinolysis breaks it all down, creating fibrin split products, FSPs, which actually inhibit clotting, so the blood just loses its ability to clot.
Terrifying. So the manifestations reflect this paradox. Bleeding signs and clotting signs.
Absolutely. You'll see bleeding everywhere, petechiae, purpura, oozing from IV sites, hematomas, coughing up blood, GI bleeds, GU bleeds, even neurologic changes from brain bleeds. But at the same time, you might see thrombotic signs. Cyanosis, ischemic tissue death in fingers or toes, shortness of breath from pulmonary emboli, ECG changes indicating heart strain, low urine output from kidney clots, delirium.
Wow. So the nurse has to be incredibly vigilant, watching for both sets of symptoms.
Absolutely life-saving vigilance is needed.
The diagnostics for DIC need to be quick. High D-dimer is key, because that shows clots are being broken down.
Yes, high D-dimer is characteristic, along with prolonged PT and APTT, because the factors are used up, and critically low fibrinogen and platelet levels. You might even see schistocytes on a blood smear. Those are fragmented red blood cells, basically sheared apart by passing through those tiny fibrin clots.
Like little torn pieces.
Yeah.
Wow. Nursing management. Rapid diagnosis, stabilize the patient oxygen, fluids, and most importantly, treat that underlying cause.
That's the core, treat the trigger. Then we manage the bleeding and clotting. Cautious use of blood products, platelets, cryoprecipitate, FFP if bleeding is severe. Sometimes, carefully, anticoagulation with heparin might be used if the thrombosis part seems to be causing more immediate harm than the bleeding risk. It's a very delicate balance.
Continuous assessment sounds absolutely vital, checking for any hidden bleeding, signs of organ damage.
Nonstop assessment, yes.
Okay, let's pivot now into blood cancers. Leukemia.
Right. Leukemia is a general term for cancers affecting the blood and blood-forming tissues, bone marrow, lymph system, spleen. What happens is an accumulation of dysfunctional cells. There's a loss of regulation in cell division, leading to this sort of cellular traffic jam of abnormal white blood cells that crowd out the normal cells.
And it's classified based on how fast it progresses
Hmm.
and which cell line is involved. Acute versus chronic, myelogenous versus lymphocytic.
Exactly. Acute leukemias involve immature cells, called blasts, proliferating rapidly. Abrupt onset. Think acute myeloid leukemia, AML, and acute lymphocytic leukemia, ALL, which is more common in kids. Chronic leukemias involve more mature-appearing but still dysfunctional cells. The onset is usually much more gradual, sometimes found incidentally. Think chronic myelogenous leukemia, CML, and chronic lymphocytic leukemia, CLL, more common in adults.
And the general manifestations often stem from that bone marrow failure, right? The abnormal cells crowding out everything else.
Precisely. So you see symptoms of anemia, fatigue, pallor, thrombocytopenia, bleeding, bruising, and neutropenia, frequent infections. You can also get leukemic cells infiltrating organs, causing splenomegaly, hepatomegaly, lymph node swelling, bone pain, even CNS irritation.
And sometimes that white count gets dangerously high. Leukostasis.
Yes, that's an emergency. The blood can become thick, almost like sludge, blocking small vessels, especially in the lungs or brain.
Treatment sounds intense. Chemotherapy and stages induction, consolidation, maintenance, plus targeted therapies, radiation, maybe stem cell transplant.
It's often a multimodal approach, and for you as nursing students, a huge part of your role is managing the significant side effects of these treatments, especially that bone marrow suppression from chemo, which leaves patients incredibly vulnerable to infection and bleeding. Supportive care is massive.
Absolutely. Okay, finally, let's talk about a really practical hands-on skill. Blood component therapy.
Crucial skill. Its purpose is really temporary support. It bridges the gap, buys time until the underlying problem, the anemia, the bleeding, can be resolved, often life-saving.
And we use different components for different needs.
Right. Packed red blood cells, RBCs, for anemia or acute blood loss to boost oxygen carrying capacity. Platelets for thrombocytopenia to help with clotting and prevent bleeding. Fresh frozen plasma, FFP, replaces multiple clotting factors when there's a deficiency, like in DIC or liver disease. And albumin is a volume expander used for hypovolemic shock or severe low albumin levels. Each has its specific job.
And the administration procedure itself is full of critical safety steps.
Absolutely. Attention to detail here prevents serious harm.
You typically need decent IV access, right? Like an 18 or 20 gauge for adults.
Yeah.
Maybe larger if you need rapid infusion.
Yes, adequate access is key. And always use that special Y-type tubing with a built-in filter. And here's a huge one. Only 0.9% sodium chloride normal saline can be infused with blood. Never dextrose solutions, they cause red cells to clump or burst.
Okay, saline only. And the absolute most critical step, positive identification.
Paramount. Verifying the right blood product for the right patient usually requires 2 licensed professionals checking everything at the bedside: patient ID band, blood bag tag, requisition slip. Barcode scanning helps add another layer of safety.
Get baseline vital signs before starting. Start the blood within 30 minutes of it leaving the blood bank.
Correct. Prevents bacterial growth at room temp.
And then the golden rule. Stay with the patient for the first 15 minutes. Infuse slowly during that time.
Yes, most severe reactions happen early. So stay, observe closely. After 15 minutes, recheck vitals, then you can increase the rate to infuse PRBCs over 2 to 4 hours.
Never longer than 4 hours, right? Risk of bacterial contamination again.
Exactly. 4-hour max infusion time for a unit of red cells.
Okay, this brings up a really important question.
Mm-hmm.
What do you do if a patient starts having a reaction? Despite all the checks, it can still happen. What's the immediate action plan?
Excellent question. Knowing this cold is vital. First, stop the infusion immediately. Don't just slow it down, stop it. And stay with the patient.
Okay, stop the blood. Stay.
Second, maintain 5V access. Keep the line patent with new tubing and 0.9% saline. Disconnect the blood tubing, but keep the IV open.
Right, saline only, new tubing.
Third, immediately notify the blood bank and the healthcare provider. Let them know what's happening. Fourth, recheck all the identifiers. Tags, numbers, patient band. Rule out a clerical error, a mismatch.
Double check everything again.
Fifth, monitor vital signs and urine output very closely. Things can change rapidly. Sixth, treat the symptoms based on the provider's orders. Might be antihistamines for hives, antipyretics for fever, fluids or pressors for shock. Seventh, save the blood bag and all the tubing. Send it back to the blood bank for analysis. Collect any required blood or urine specimens from the patient too.
Don't throw anything away.
Nope. And finally, eighth, document everything meticulously. The reaction, the interventions, the patient's response, everything.
That's a clear protocol. Stop, stay, saline, notify, recheck, monitor, treat, save, document.
Exactly. And there are different types of reactions to be aware of. Acute hemolytic reactions are the most severe, usually ABO incompatibility giving the wrong blood type, life-threatening. Febrile non-hemolytic reactions are actually the most common, usually a reaction to the donor's white blood cells, causes fever, chills. Then you have allergic reactions can be mild hives or severe anaphylaxis. Transfusion-related acute lung injury TRELA-I, this is actually a leading cause of transfusion-related deaths now. Causes sudden acute respiratory distress. Other risks include sepsis from contaminated blood, circulatory overload if infused too quickly, especially in patients with heart failure, and delayed reactions that can happen days later.
Wow, lots to watch for. Prevention sounds like it really hinges on that meticulous patient identification and maybe using special filters sometimes.
Absolutely. Careful ID is number one. Leukocyte-reduced filters can help prevent febrile and some allergic reactions, and careful volume assessment prevents overload. Management is always about stopping the infusion, supporting the patient, and treating the specific symptoms.
Okay, so wrapping this all up, what does this mean for you, our listeners, as you head into your nursing careers? This deep dive really shows that hematologic problems are incredibly diverse, right? Often like a complex puzzle. But they all seem to share those core concepts: cellular regulation, oxygenation, hemostasis. Your ability to connect those dots, spot subtle signs, do accurate assessments, and provide vigilant nursing management. It sounds absolutely paramount. Your attention to detail, your critical thinking can be a real game changer for these patients.
It absolutely can. It really highlights the critical role you play as a nurse. Monitoring constantly for complications, bleeding, infection, organ damage, and providing that thorough patient education, especially for chronic conditions like sickle cell or hemophilia, or for therapies like transfusions. Your insights, your actions, they directly influence patient outcomes in really profound ways.
So as you move forward, maybe consider this. How will understanding this intricate dance of blood cells, from how they're made to what they do to how they clot, how will that inform your ability to see the whole patient? Looking beyond just the primary diagnosis to provide truly holistic, maybe even life-saving care. It's all about connecting those physiological dots back to the actual person in the bed. From the entire Deep Dive team, thank you so much for listening, and thank you for your incredible commitment to learning. Keep digging for those nuggets of knowledge.